is Grigorios Korosoglou, and I will present you the results of our study entitled The Safety and Effectiveness of the Rotarex Thrombectomy System Combined with Drug-Coated Balloon Angioplasty in in-stent restenosis and in-stent occlusions, a prospective two-center study. Conflicts of interest. This research project was supported by BD in form of an institutional grant support. Now, stents in form of permanent metallic implants still play a major role with femoropopliteal interventions, despite the emerging role of drug-coated balloon angioplasty. And we also know that in cases of stent failure with in-stent restenosis or occlusions, this remains a major problem, increasing the number of reintervention rates. So we need more effective treatment strategies to tackle in-stent restenosis and occlusions. We published a global endovascular treatment algorithm for chronic femoropopliteal lesions in JACC cardiovascular interventions. And as you can appreciate, experts from different countries and different disciplines like vascular surgery and cardiology strongly recommended the use of debulking techniques by mechanical thrombectomy with vessels containing organized thrombus and also with in-stent restenosis and Tosaka 2 and 3 lesions. If we take a look at the scientific data with this problem, we can appreciate that not so many studies investigated the role of mechanical thrombectomy in in-stent restenosis and occlusion, and the studies which did so were primarily single-center and smaller studies. And we also have to mention that in most of these cases, mechanical thrombectomy was not necessarily used in combination with drug-coated balloon angioplasty. The aim of the present study was to assess peri- and post-procedural outcomes with mechanical rotational thrombectomy combined with drug-coated balloon angioplasty for the treatment of subacute and chronic limb ischemia due to in-stent restenosis and stent occlusion. Our safety endpoints were perforation and peripheral embolization, and the primary endpoint we used was freedom from CDTLR, clinically driven target lesion revascularization, and primary patency during the follow-up period. The results of our study were published last year in the European Journal of Vascular and Endovascular Surgery. Study period between 2017 and 2023, we recruited patients with Tosaka 2 and 3 lesions due to stent restenosis and occlusion, after exclusion of some patients due to acute presentation or due to Tosaka 1 lesions, or some patients who refused study participation. We had an overall study population of 215 patients, which we subsequently analyzed. You can appreciate the clinical characteristics of our patient. We had a median age of 73 years old. About 60% of the patients were male, 44% with diabetes mellitus. On the other hand, in regard to the clinical presentation, 74% of the patients presented with chronic limb ischemia, about 40% of the patients with lifestyle-limiting claudication, the remaining patients of about 60% with chronic limb-threatening ischemia. And in regard to the technical characteristics, we had long lesions to tackle with a median lesion length of 22 centimeters, and in 42% of the cases also inclusion of the popliteal segment. What about the technical details of the treatment? So about 50% of the in-stent lesions were treated with a 6 French device, the remaining with the 8 French Rotarex device, All lesions were treated with drug-coated balloon angioplasty in combination with debulking, as already mentioned. In about 24% of the cases, additional stent placement was also necessary, in addition to debulking and DCB. And what about the safety of our procedures? We had 0 perforation and 3% of peripheral embolization. In addition, we have to mention that lysis prior to the index intervention was necessary in 22 patients. You can see the effect of Rotarex mechanical thrombectomy 2 lumen gain without barotrauma, and the effect, the combinative effect of debulking plus balloon angioplasty with reduction in terms of lumen narrowing. You can appreciate the follow-up results of our study, our main endpoints. You can see a clinically acceptable CDTLR rate with about 20% of our patients needing to undergo CDTLR during the study period, and an estimated CDTLR rate of freedom from CDTLR of 95% at 12 months, and a primary patency rate of about 80% after 12 months, despite the complexity of the tackled lesions. Predictors of CDTLR and loss of patency, as investigated, as assessed within Cox proportional regression models, you can see that diabetes mellitus and long lesions were predictors for CDTLR. In addition, additional stent placement during the index procedure was also predictive for CDTLR, which was also predictive for loss of patency. And of course, Rutherford categories were also predictive for a loss of patency during follow-up. The limitations of our 2-center study and the fact that this was a single-arm study, we can conclude that Rotarex mechanical debulking in combination with drug-coated balloon angioplasty is a safe and effective procedure for tackling subacute and chronic in-stent restenosis and stent occlusion. Lesion length and the additional stent placement during the index procedure may predict increased reintervention rates associated with worse patency, and of course future studies in order to compare this treatment algorithm with others, such as the implantation of covered stents or bypass surgery or other debulking techniques, are now warranted. For attention on behalf of my co-investigators, and looking forward to seeing you in Paris at the next PVI conference. Bye-bye.